Well, good afternoon, good morning, wherever you are. My name is Paul Brasler, and I'm here to talk today about a new book I've gotten out through PESI called The Clinician's Guide to Substance Use Disorders, Practical Tools for Assessment, Treatment, and Recovery. This is actually due to be released by PESI on October 4th, and I'm really excited to talk with you guys about it today because I like talking about substance use disorder. It's kind of a weird thing, I guess, to like to talk about it because I see a lot of hope in the ability to treat people living with SUD, and so just really honored to be able to do this, to work with PESI on this. They're great to work with, and just really hopeful that this is something that can help you out in your clinical work if you're a clinician, and it's also meant for folks who aren't clinicians as well, and I'll get more into that. But we've already had a few questions posted today, and so I want to just go ahead and get right into that and use those to kind of guide what we're talking about today. And you have an opportunity yourselves to type in a question and post it, and we'll try to reach it. We'll definitely try to get to it, and hopefully give you the answers you need. So I think our first question is, just move this little box right over here. Okay. So the first question is, what do you think is the biggest myth out there about substance use disorder? That's a great question. And I think if I have to, because there's a lot of different myths about SUD and stigma about substance use disorder, SUD, also called addiction. Stigma is the main reason why people living with SUD don't receive help. Stigma about being able to get help, stigma within the treatment community, and within society as a whole. But I think the biggest myth is that SUD is a one size fits all situation, and we know that's just not true. That SUD affects everybody uniquely, not just in what a person uses and how they use it and how it impacts their life and how they respond to treatment and how it impacts the people around them. So I think the biggest myth is that SUD is this linear process that most people go through in the same way. And we know that's simply not true. Unfortunately, many of our systems of care continue to be set up on that supposition that everybody kind of goes through SUD in the same way. And only now, through the efforts of SAMHSA, through the American Society of Addiction Medicine, and other organizations, only in the last really few decades have we begun to emphasize the importance that quality SUD treatment is individualized. And so I think that that's something that we still struggle with to this day. So great question. Let's see what the next one is. All right. I'm not a CADC, certified addiction or drug counselor. Okay. In Virginia, which is where I'm from, I live in Richmond, Virginia. We call them certified substance abuse counselors. But so basically, the question is, I'm not a CADC, but I often see clients who are struggling with substance use disorder. Am I outside my scope of practice? I would say you're not. I think it also, though, depends. If we go back to my first question about things being individualized, I think it depends upon the situation. I think part of what we have to look at is the need for a quality assessment, finding out how substance use disorder is impacting all the areas of the individual's life. And clearly, in cases where there is higher levels of medical comorbidities, psychiatric comorbidities, co-occurring disorders, and things like that, it may be that the person needs a higher level of care. But when we consider the fact that most clients with SUD also have, to some degree, a co-occurring mental health or behavioral health disorder, it's understandable that most of us in the mental health field are going to have some interaction with people with substance use disorder. It would really be almost impossible for that not to happen. Likewise, if your focus is substance use disorder treatment, it would be almost impossible to have contact only with people with SUD, right? So I think it is not inherently outside the scope of your practice. But if I can just kind of elaborate on this a little bit, I think it's a very good question, and it's probably the number one question I get asked when I'm at a PESI event, which is, or not even so much a question, but a statement, to where a person says, I don't know how comfortable I feel. I don't feel I am knowledgeable about this. Or sometimes people will even say, I don't feel I have the personal experience that allows me to communicate in that way. And I think that those are all good. Those are all good concerns and questions. The main reason I wrote this book is for people like the person that answered this question. In my experience, most of us, I'm a licensed clinical social worker. I've been an LCSW now for 20 years, been a social worker for 25 years. And like most of my colleagues, I had little or no education in SUD and SUD treatment as part of my master's program. In fact, that's the number one thing I hear when I'm on the road with PESI, whether I'm teaching a class on substance use disorder or teaching a class on high risk clients. Is I wish I could have learned more. And the thing is that while there are some exceptions, our institutions of higher learning across much of North America continue to lag behind when it comes to SUD treatment. We've been siloed for so long. And so I think that what we have to look at is, how do we increase our knowledge base? And that was my primary reason for writing this book. I have a passion for this, and let me just explain how I got here. And the nice thing about this book and how I was allowed to write it was, there's a lot of personal, clinical, and not personal, but clinical realism to it, because I use real stories from my practice. So when I started out in the field of social work, I worked exclusively with kids. I worked with teenagers, older kids, most of whom we would now realize today have some degree of trauma. We called them emotionally disturbed. This is in the 90s. Not a very nice title, but and we would now realize that what I was dealing with was kids that were horrendously abused. And so we would realize that most of them have PTSD or some level of trauma, and in some cases, other mental health issues, and occasionally SUD. So I was doing that for about 6 years, and I was in my MSW program part-time, and they asked me, they said, okay, your first placement, your first internship is coming up. What population do you want to work with the least? What population do you not want to work with? And being the naive, overly trusting, possibly too eager to please individual, I wrote down on the paper, and probably in block letters, people who are addicts. And I even think I added, because they can help it. I mean, I was that self-righteous and young and whatever. So the school, to their credit, placed me in a residential program for women who had opioid use disorder and cocaine use disorder. And it was a 40-hour-a-week placement over 13 weeks over the summer. And it was one of the hottest summers in Richmond. This facility, the air conditioning wasn't working. It was incredibly underfunded and poorly managed, structurally, not so much treatment-wise. And I had this bias toward people with SUD, because most of the kids I worked with in residential treatment and in a shelter for homeless teens, most of them were there because a loved one's substance use disorder. There was a correlation to that. And so I assumed that, well, since bad things have happened to these kids, the people that did those bad things, being under the influence of drug, they must therefore be bad. And I quickly learned, as I sat and listened to the stories of my clients in group and individual therapy, and I had my ears and my eyes opened. And I realized they're no different from the kids I'm working with. They're just in a different place in life. And that really got me interested in asking the question, how is it that simple molecules can radically alter a person's behavior. So I set out to learn as much as I could about drugs. And that led me to the majority of my work working with kids, when I say kids, teenagers and adults with SUD and co-occurring disorders. So this book was written to say to that person who was doing what I was doing, hey, here's a resource for you. This is a way, it doesn't have all the answers, but this is a great starting point. This is what I really wish I had learned back in the day. So that's what it's there for. So you're not outside your scope of practice. Next question, please. What are your thoughts on legalization of marijuana and related products like D8 gummies? That's a tough question. First and foremost, making something illegal doesn't mean people are not going to use it. Okay. There are a lot of things that are illegal right now that people continue to do. I think that what we have to look at is the inherent risk of a particular substance versus the penalties we put on people for using that substance. So when we look at the inherent risk of cannabis or cannabis products, most cannabis products, so if we separate out delta-9 THC, which is typically what we mean by marijuana, which is more psychoactive, and other products like delta-8, delta-10, or the cannabidiol products, CBD, CBG, CBN, then basically, if we look at the inherent risk there, the penalties do not equal the risk. So I think that making something illegal has not really changed anything. I think that if we do legalize it, first of all, I think it's up to the individual states. Second thing is I think that we need to be honest with people about the inherent risk. Cannabis is much safer in many ways than alcohol overall. Okay. But it is not without risk, particularly when used by adolescents and young adults, particularly when used heavily. Likewise, products containing high amounts of THC, delta-9 THC, can lead to a host of other medical problems, including hyperemesis syndrome, which is continuous vomiting, and can potentially affect a person's mental health. So we need to be honest with people. We don't need to scare people, but to be able to tell somebody that cannabis is as dangerous as illicit fentanyl or methamphetamine is simply disingenuous. It also causes us to take very useful chemicals like ketamine, psilocybin, dimethyltryptamine, MDMA, drugs that are often grouped under the umbrella of psychedelics that are finding a lot of great help in helping people with trauma, with depression, and things like that. It's interesting, for the last couple of years, not only have I been doing work in helping people with substance use disorder, I've actually been spending about half my time, about 2 days a week, working in a ketamine infusion clinic where I provide ketamine-assisted psychotherapy. And some of my clients there are people with substance use disorder. So ketamine is significantly safer when used appropriately than certainly things like heroin, cocaine, fentanyl, things like that. So I think again, we have to look at the inherent risk versus that. Cool. Next questions. Okay, and we did. Thanks, Kate, for putting this. So this is the book, by the way. It is available at PESI.com. I've got a. I'm sorry. So the Clinician's Guide to Substance Use Disorders: Practical Tools for Assessment, Treatment, and Recovery. Very nice looking title. So anyway, so check it out. Another question for us, please. Hi, Paul. I'm wondering how you stay grounded doing this work. Recommendations. Well, right now I'm drinking green tea. How do you stay grounded? Well, first and foremost, anytime I do a class or a webinar, I just finished 2.5 years of doing webinars for Medicaid providers in Virginia, where I live and work. And every time I do a webinar or I do a class for PESI, I always start out by what I call my no-duh statements. And the first statement is you have to like people. You have to give a damn about people is what I say. And so I think that, and as I explain, You have to give a damn about people, and then you have to find a way to connect with the person you're working with in that moment. The reason I start out with those no dust statements is I acknowledge from the beginning that, guess what? I cannot teach you as a human being to care for another human being. I don't believe that can be taught. I've actually had people come up to me during classes, after classes in PESI, and really nice about it, saying, I think there is a way to teach it. I'm like, great, do it. I think a lot of that comes from our own values. So I think part of it is reminding myself why I do what I do. So that's the first thing is remembering why I do what I do. The second thing is to recognize and celebrate small victories. And what does that mean? It means a client getting it. It means a client making a small change. It means a client showing up when sometimes just showing up is part of the work. So recognizing those small victories, celebrating the small victories. Collaboration is key. Even in private practice, there has to be a degree of collaboration. Of shared, we can call it supervision or whatever, but I run a supervision group for three people with MSWs working to become licensure. I utilize that. I mean, yes, they're staffing cases with me because I'm the supervisor, but I'll also say, hey guys, I had this really interesting thing happen the other day at my clinic, and I want to discuss it. So I think that's the other thing. And the next thing, I don't know if it's fourth or not, is keeping work separate. I think that is really important. Having something to do outside of work that is very different from what you do. Exercising is extremely important. I would say eating right, but I don't always follow that, so I'm not going to say it. But doing things differently. I'm a musician, not very good, but I am. So, and I run and I garden and we're still trying to train this new puppy wherever he went. But anyhow, so I think that's how you stay grounded. The last thing is you also want to keep learning. When you find something you really like to do, it's not work. And to me, this field, one of the reasons I love working in SUD and SUD treatment is that it's always changing. It's always evolving, always a chance to learn something new. So that's a great question. What do we do with clients who are in deep denial and there's no minimal change? I think we go back to the basics. One of the things I ask clients, the first thing I ask a client when I meet with them is, why are you here? And again, I ask them that and allow them a chance to talk. I mean, that's what I want to find out. Why are you here? When I worked at a clinic where we provided medication for opioid use disorder, specifically a medication called Suboxone, I got really specific because a lot of the folks I was working with there, about half of them were either living on the streets or had really unstable housing. And a lot of our clients were living hand to mouth. And I'd say, there's 8 steps from Grace Street to our lobby. What made you walk those 8 steps this morning? And a lot of times there was a reason. A loved one has died of an overdose, things like that. So, let's find out that reason. So what I want to do is help a client. Okay, let's go back to, why are you here? And what does change look like? And this is where it gets tricky, because let's say you have a client that comes in and says, I want to deal with my heroin use disorder, my use of heroin, but I don't want to stop using cannabis. Okay, let's deal with that. Let's deal with that first thing. And we may never they may continue to use cannabis. Okay. So at that point, I'm looking at, okay, what is the greater harm here? Even if it is something I don't necessarily agree with, what's the greater harm here? So we begin looking at changes. We redefine what change means, and we move away from all or nothing thinking. I think that's the other thing. I think with people that are in denial, my question is, why are you here? Why, what brought you in today? Because there's a reason the person is here. But we reorient that aspect of change. Cool. Other questions? You guys are asking really good questions. Where can I learn more about your book and trainings? Okay, great. Well, you can learn more about my book. It is available at PESI. and they have all basically list everything there with it. I also do a 2-day certification course for certified addictions informed mental health providers. That's also through PESI. And the that certification course is actually formed somewhat the basis of the book. The book expands on that course, but that's a great place to start. I'm actually speaking. I'm also speaking rather at the Addiction and Trauma Conference on October 5th in Vegas. One of the speakers there, and really excited and a little nervous about that. But I'm talking specifically then about medications for opioid use disorder. And I've got classes. I got another class I do called High Risk Clients that we're actually re-recording. It's already recorded now, but it's a few years old. We're going to re-record it in December, and that covers some aspects of substance use disorder, but delves deeper into suicide, violent clients, and how trauma is often misdiagnosed and sometimes mistreated. So that does a lot with assessment too. This book here has a lot on assessment, screening and assessment. It does a moderate dive into the different substances that people use, and this is up to date as of this fall. It does a lot in terms of treatment. There are a lot of different worksheets within it. There are things that you can use as exercises to practice. There are worksheets that you can copy, some to give to your clients, some to, that just have information, some that are things that you can use outside of session as if you do homework. You don't have to, but you can certainly do that. Some you can use in session. And so really excited about that. A lot of stuff on co-occurring disorders as well, and stuff on groups, working with families, ethical considerations, cultural considerations. We put a lot of stuff into this book. So again, you can order that copy today. If you notice, that's a great question. Order your copy at www.pesi.com/Brasler. That's me. Cool. Any other questions we have? All righty. Well, listen, I really appreciate you taking the time to watch this today. I really do. I want to thank you for the work you do, because we're all trying to help out our fellow human being, and this is how we do it, by continue to expand knowledge and share ideas. So I hope I get a chance to meet you out on the road or later this year, the next few years rather. And just want to thank you guys for what you do, and take care and have a great weekend or